So let's go on to this issue of MRD, which you mentioned, Andrew. It's got attractions, I think, because it tells you about individual patients. Now, there are two approaches, the NGS or flow. They both have challenges. What do you think the strengths and weaknesses of either technique is?
The flow cytometry is more easy to, set up in laboratories, especially without access to high-tech molecular services, and it's a kind of a generic morphologic type approach to assessing the presence of blasts. However, I think it doesn't give us the granular information that I think I find useful when using gene-specific probes, particularly like NPM1, because the level of confidence and the sensitivity of the technique is extremely high and very reproducible, and is something which could be standardized between different laboratories, whereas we've continued to struggle having flow cytometry used as a general purpose MRD marker, and it tends to be restricted to centers of excellence.
Yeah, I think also, you've got, even in the MRD negative, you've still got a fair number of relapses going on, and maybe you just missed a sample that's relapsing. But in addition, in an MRD positive, they're not all failing either, so it's not clear why that's happening. But it certainly opens up the challenge of assessing treatments prospectively in the context of whether a patient was positive or negative at a certain time. What's the flow experience in the US, Mark? My impression is they're going more towards NGS than flow, generally speaking.
I think that's clearly going to be the case. We're busy running around talking about digital droplet PCR to identify specific mutations and cell-free DNA and so forth. The flow, we're quite comfortable with it for ALL, but not for AML. Again, I'm afraid the concept of the brilliant artist localized at one or two institutions remains a problem. And so widespread use is going to have to come through usually nucleic acid.
Yeah, I think there is observer experience involved in flow that's much more obvious in AML context than in ALL context. What about clonal hematopoiesis backgrounds, though, as far as NGS is concerned? How big an issue, and how can you deal with that?
Oh, it's huge. Now that we're actually, without realizing it, doing these big panels on random people, we're finding all manner of things. And one issue that wasn't talked about here was familial AML. It's a lot more common than we realize. Yes, I've got a family history of cancer, not so much. I've got an aunt and a brother. Okay, you've got a mutation in ATM. You've got a mutation in DDX41. That's actually your problem, and that is much more common than we realize. So we're finding, and this speaks to how well we've advanced in our understanding of how the disease comes about. This slow process over the years. Oh no, it starts at age 70. No, it starts at age. No, it starts at age 50. Oh, it pretty much starts at birth. It starts when your stem cells start dividing. The longer you're on the planet, the more chance you have to make a mistake.
So going back to new drugs, you've got IDH1, IDH2 inhibitors, 10 to 12% of younger patients, half of whom with conventional therapy don't appear to relapse. So it's a major challenge to show their impact. So my impression is there's a fair body of opinion that wants to jump to combos with them or combine them with standard chemo. That's fine. We may find an answer in 5 or 6 years as to whether that's a good idea, if we're lucky. It seems to me, Mark, about the new FLT3 inhibitors in the next year is going to present some approvals, maybe a couple of approvals.
Sure, probably in a couple of approvals, or at least one more approval. But then we're not going to really know how to use. But we're already positioned. The trials are already rapidly accruing that will tell us how to use the darn things. We won't get a readout on those for 2 or 3 years, but we're going to get that. It's coming fairly quickly.
Okay, but you're going to end up that if you add quizartinib to your chemo, it's beneficial, tick. But there is a standard of care currently out there. Does your control arm have to be midostaurin, do you think?
Well, but that trial is going to be accruing quickly also. I mean, you know, we're not going to get a readout on quantum first for, you know, probably still a couple of years. You watch, the Europeans are going to get the machine going, and you've got this gilteritinib versus midostaurin trial roaring ahead. I have no doubt it will accrue reasonably quickly, and they'll use event-free survival as an endpoint. So, you know, we're going to get that readout reasonably fast. I think we'll look at survival. Everybody looked at the ratified survival curves and said, some people said, meh, but if you see a much more pronounced hazard ratio or difference with quizartinib versus placebo, there's a biologic rationale then.
The method we use to measure the presence of FLT3-ITD is obviously not very sensitive, but you've done some work showing some more sensitive methods.
And that actually is key, getting back to MRD, getting back to a nucleic acid form of MRD. That's a component of that. If you can basically say, look how deep the remission is, at least for the marker that we're targeting, using this PCR NGS sandwich assay that multiple groups are developing. It's not hard technology. You can really track this thing deep, and if your treatment makes it go deep, that's very reassuring. It explains a lot of what we see. So in other words, the more data, the more light that's shined on the results of that trial will make people perfectly comfortable to switch their so-called standard of care.
Presumably there must be more patients positive than we realise if you had a more sensitive technique, and with the lack of correlation between the level and the potential benefit of these FLT3 inhibitors, maybe we're missing some patients that might benefit from the treatment.
There's an association with the level and survival. We kind of showed that. Just a sheer measurement will make curves separate with this assay, and I think that's an endpoint on all those phase 3 studies. That assay, done by different institutions, slightly different methodology, but essentially in principle the same assay, is a hard endpoint on those, and so that we'll get that readout.
My impression is that FLT3 by NGS is tricky because of the size issues. Is that being resolved?
Yeah, that's resolved. What you do is you put PCR primers flanking their area of interest, amplify it up just a wee bit, enough to make it outcompete the non-FLT3 DNA, and then chop that up, put that on an Illumina panel, and you can get, you know, a very sensitive allelic burden down to, you know, 1 in 10,000, 1 in 100,000 routinely, and it turns out, not surprisingly, it's right there at 1 in 10,000 in most patients, right after remission, a good clean remission. No, it's right there. Of course it is. And so, you know, making that go negative will be.
Vyxeos, liposomal daunorubicin RSE. Interesting, because the phase 2 studies only showed a benefit in the adverse risk patients, hence its evolution as an adverse kind of targeted thing. Difficult to understand in the context even of the experience of daunorubicin intensification, why Vyxeos wouldn't actually have done something in the intermediate or more favorable patients, but it didn't. And I don't think anyone really understood why not. But clearly, when it came to Europe, there was no experience of using it in Europe. When it came to Europe, the kind of doubts were expressed, well, you're only up against 7+3. So it's clearly going to face some quite difficult challenges, I think, as it moves into different situations. But it's the technology behind it that I think anyone who's done lab experiments and looked at synergies or ratios, etc., of different agents in combination knows that different ratios produce better results, and it goes up and down, and they publish the best ratio available. So there may well be other combinations out there if if the principle of putting it in a fixed ratio really is what's making the difference. But of course, there is, the liposome itself is not a random thing. I mean, it is engineered to accumulate in the marrow. So this is not a chance, a wee lump of fat to stick drugs in. This has been carefully thought through. But it would be interesting to see whether this could be applied to other combos and whether it would make them more efficient. And I'm just wondering if, you know, like your venetoclax IDH1 or 2 or something, putting a liposome could have a future. I mean, is it a crazy idea?
I think it sort of is, because the main problem that the liposome gets around is it keeps the daunorubicin from your skin and gut and things like that and keeps it in the blood. I don't know that we see any toxicity from an agent like venetoclax except to the bone marrow. So, and that's where the liposome gets to.
Just tell us the story, the myeloma story on venetoclax, if you know it, because it's obviously been put on hold in that context. So why is that different?
You're referring to the study which combined bortezomib with dexamethasone, and the study was halted because of an increased number of deaths in the venetoclax-containing arm. The full picture as to what was going on is not available. However, I think the suggestion is that there was an increased number of septic events, and presumably that led to increased numbers of deaths. So the question is, why was the venetoclax-containing arm more toxic with respect to sepsis? One hypothesis I have is that venetoclax is a PGP inhibitor, and that perhaps in combination with some drugs, I'm not sure if bortezomib is a substrate, but it could inadvertently increase the concentration of the drug in not just the normal cells, but the malignant cells. And normal progenitors actually have very high levels of PGP. So in fact, the normal progenitors might suffer more and hence lead to the myelosuppression. And this could also be an issue with venetoclax being combined with other cytotoxic combinations, particularly if they're PGP pump substrates.
Now, I was quite reassured to see that most people are feeling that these drugs, these new drugs, which have very, they have very interesting mechanisms, etc., are moving more front line. But as they move more front line, the practical challenges of delivering these studies increases, in my view. So you were talking, Andrew, about a sort of master protocol, which I think is more recognized by regulatory authorities as a reasonable thing to do. Would you like to just summarize what you're talking about?
Yeah, so at the moment we have more partitions and segmentation of AML, which means doing subgroup studies now becomes more challenging. And Bob Lowenberg discussed the HOVON approach, where they're getting together many countries to do an IDH randomized study, and this will require 7,000 patients to be screened to find the appropriate number of patients to get an adequately powered event-free survival endpoint. For us folk in Australia, where we don't have
7,000 people,
7,000 people with AML, we have to come up with more, I guess, innovative approaches to do trials where we can get useful information. And the thing that's always puzzled me is that to do all these different combinations, you have to literally open 6, 7, 8, 9 separate trials, which drives our governance office and our coordinators spare. So every patient relapses ultimately, if they're not cured, obviously, and they'll have a different clone that might be targetable. And the point of the master protocol is to find some way where we can unify different drug combinations into a package whereby we can recycle the patient onto new combinations when they fail combination A, move them onto combination B, rather than a new study. And to provide pharma with a way of integrating their new drugs more seamlessly into a master protocol, similar to how you ran the pick a winner type of study.
So I mean, they could be in C, they could be in D, they could be in E. So the patients that hit randomization E could vary quite a lot in terms of what they've been through and, you know, whether or not their disease evolved. How do you sort of control for that?
That's no different to how we do relapse refractory studies anyway. There's people that have 1 to 15 prior therapies, but I think the most informative information is what was the target, what happened to the target, and did doing something to that target have a patient benefit in terms of prolongation of remission, and if the patient didn't have a benefit, what other things were going on at a mutation or non-mutational level that might have been causing resistance. And I think we can gain lots of information from looking at individuals, not necessarily controlled because of prior clinical or other factors, because what we're looking here is purely the drug versus the target. And each patient has often 5 or 6 different mutations, and so each patient actually gives us 5 pieces of information. And if we can recycle that patient onto multiple drugs, then we can get much more data than we can from just putting one patient onto one trial, looking for one survival endpoint, and then again trying to find another 7,000 patients to do it all over again.
Yeah, this is similar, not the same as, but similar to the BEAT approach, where they look at the molecular signature.
Try to classify every patient,
and try
literally not just molecular signature, but even maybe even in vitro assays.
Yeah. Now, I've not heard too much about that program in terms of how it's expanding or getting on or delivering.
I think all they can say
because it's not these interventions are not randomized. Are yours randomized?
No, not randomized because
so they're exploratory.
Exploratory, yeah.
And I think that's what this is too, and I think that to some degree there was a sense, part of it is limited by what drugs are available. And so, well, it could be this, it could be that, it could be this. What drug do we have? That one. Well, that's what they get. So, you know, it may be limited by that in a lot of ways, but if they get enough drugs, even then, the lack of randomization, the uncertainty of, you know, it's really a big pilot trial more than anything. And my one concern with Beat AML, I'll be honest, is they don't quite pay attention to the pharmacology. The drug in the dish is not the same as the drug in the patient and the drug interactions that you're talking about. And that is the lack of control over that concerns me, that there'll be more noise than signal.
So just reflecting on the meeting as a whole, how did you were there advantages, disadvantages in the meeting in terms of the general format? Speakers were invited to talk for short periods of time with long discussion periods. There was quite a lot of intermingling out off the formal part of the meeting. Did you think this worked as a meeting? Did you find it beneficial?
For me, I could honestly say it's probably one of the most enjoyable meetings I've had in the last 12 months, mainly because it wasn't as packed and rushed as many other meetings. And I think the short time format forced us to be more diligent about choosing what was relevant and what was provocative, and then having very relaxed discussion amongst a smaller group of people is really a format that is almost a bit of a dying breed of meeting at the moment. So I really enjoyed it and got a lot of good interactions with pharma. I think the pharma people had very good access to, KOIs here, and we had good access to them and good access to catching up with good colleagues.
Yeah, I think the whole concept of get up and say a few quick words and then start the argument is more fun. In fact, I would expand more on that. I would, have a gong. Okay, you have 10 minutes. Talk fast because we really want to start arguing. That's the fun part.
The other thing is that you've got quite a number of disciplines, preclinical and clinical, involved, which is interesting. And also, I think the age of the KOLs or the speakers has dropped from previous meetings that I go to.
Some of them are fresh out of high school. Looks like.
So you look forward to the next year meeting. Okay.
Yeah.